All right, today we're going to look over orthopedic trauma. So first, we're going to take a quick look at what kind of makes up the musculoskeletal system, focusing mainly on most of the bones throughout the rest of this lecture. We'll talk a little bit about ligaments and muscles, but the majority of this will be talking about bones, fractures, and the different overall things that can kind of go wrong and how we'll deal with that in trauma. While there's a lot more bones in here, we can see the two main subsets differentiated by color are going to be the axial and the appendicular. Axial being kind of the central area of our central skeletal system, and the appendicular being mostly our limbs, but to include part of our pelvis and legs. Talking with some of about the classifications of our musculoskeletal injuries. Any type of injuries typically result from, particularly when we're dealing with the trauma, result from traumatic forces to the entire musculoskeletal system. It can result from direct trauma, indirect trauma, and pathological conditions such as arthritis, malignancy, and can be exacerbated by things like osteoporosis and other similar. Our first look at we'll look at the different types of fractures that we typically talk and see and talk about within EMS and kind of orthopedic injuries in general. First is our complete. We see it's just a fracture that goes all the way through the bone and causing a complete separation between between the two sides of the bone. The examples all here are the same bone. It's the femur, and so we'll talk about a couple of them. Next would be our incomplete, as you would imagine. It's not a fracture that goes all the way through, but instead just partially fractures the bone. Many of the bones that we fracture end up just being like this, particularly when it's simple and not a ton of energies involved. Transverse, next, it's moving from directly across the transverse plane from one surface of the bone to the other, straight across. Next is comminuted, and it's more the shattering. There's no solid structure difference between the two ends of those broken bones, and it's just kind of there broken up in multiple pieces. Impacted is typically more from fall injuries where the break happens, but it just kind of happens due to more of like the impact head on. And then oblique, hitting at more of an angle that we see right there. And finally, the spiral fracture, which we tend to see a little bit more in children, but we do see in adults as well. A lot of times, particularly with what happens, you'll see it in sports injuries or areas such as like skiing, where part of their limb is immobilized and the part of their body rotates through. In ski, like snow skiing, what happens is they'll be going down, their leg will catch up, but because those boots don't allow a lot of movement, they can twist and catch, and the rest of their body will continue moving, and it'll cause that spiral-like fracture. It has a lot more to do with, and a lot more to repairing that needs to be done, typically surgery and or longer recovery times. Some more classifications that we can talk about. Sprain, injury of a ligament. It's graded by severity. As of now, although one of our students recently who was more into PT prior to coming to EMS said ice is going a little bit more away, but ice during 24 to 72 hours generally helps pain and swelling, so you still might see that answer. I'm not changing that until I see some more official documentation, but I can definitely see that being decent reasoning on why that happens. And the reason they said they're getting away a bit more from ice is that it actually reduces the amount of swelling in that area, but it also reduces the amount of blood flow, which brings in more healing factors. When more definitive information comes out, I will pass it along. Strains is an injury to the muscle or its tendon from overexertion or overextension. And we see these a lot. So just remember strains, muscles and tendons, sprains, ligaments. Joint dislocations, normal articulating ends of two or more bones are displaced. Dislocation should be suspected when a joint is deformed or does not move within the normal range of motion. Complete dislocation is called a luxation, and incomplete dislocation is called a subluxation. So there's that. We see these a lot in sports injuries, and we can sometimes get called this. Remember, we don't reduce in the field as far as moving things back. If the patient has for example, some people have a propensity to dislocate their shoulder rather easily, and they sometimes need some help moving it back in. We do not reduce, but if they need some help, absolutely encourage them. Maybe give some pain meds afterwards. Some stuff we can do. Signs and symptoms: extremity trauma vary from discomfort to obvious deformity or open fracture. That makes it real easy. Some of the small incomplete fractures where we can kind of get a little bit in trouble if we're like, oh yeah, there's just nothing big, nothing wrong there. Go ahead and just sign here AMA, and then they end up having a fracture, and they can have some issues that come along with that. So things to be aware of. Field evaluation should be rapid. Not spending much like trauma. We're trying to stay on that 10-minute golden window. Field should be rapid. Things that we're looking for: pain, palpitation, or movement, swelling, deformity, crepitus, that grinding of the bones, decreased range of motion, false movement. Something's moving like it shouldn't. I've had some pictures up in previous lectures, but you might see a extra elbow in there from a fracture or something else, and there's some more imagery that we can look at here in a few. And then decreased or absence of sensory perception or circulation, distal injuries. We see this in dislocations, and we can see it in fractures too. Whether it's from bleeding and from dislocations, it's usually from a pinched nerve or pinching of the blood through there, so of the blood vessels through there, acting how a tourniquet works. But that injury to the bone can cause, or injury to the bone or joints can cause lack of circulation. And we got to worry about that, particularly in elbows, and we'll talk about that in a bit, just because they have a higher propensity to have all the nerves and joints and blood go right through that area. And so long as we have circulation, we don't want to tend to move it around too much. So we're going to first check our primary survey, looking for life-threatening conditions. Never overlook musculoskeletal. We can take a look at it, make sure it's there, and we might have to go back and treat that or splint it when we get a chance. We don't always get a chance to do it in our immediate life threats, but we need to go ahead and take. Grotesque injury should never distract. We say that, easy to say, harder to do sometimes. Some injuries, no matter how veteran or how long you've been in this field, sometimes you'll see it, and even if it's just a wow factor, I have not seen the inside of that before. Or you might see tendons move around, and you get a little bit distracted by either fascination and or just the grotesque nature of that injury. And if it's bothering you a little bit, kind of cover it up slightly, bandage it up when we get the chance. Don't let it distract you, because it's already distracting the patients. Our 6 P's that we're going to talk about: pain, patient has pain; pallor, skin signs and particularly if it's just pale distal to the injury, we can assume a little bit of a lack of perfusion. If it's pallor all over, then we know there might be more bleeding going on, enough that it's causing them to lose circulation. Paresthesia, not able to feel. Pulselessness makes sense. We need to go into that. Paralysis, unable to move. And poikilothermia is the inability to regulate temperature, whether it's really, really hot or really, really low or just abnormal. And we see this a bit more in compartment syndrome type injuries. So evaluate the extremities neuromuscular status by assessing distal pulse, motor function and sensation, CSMs, PMS, whatever you want to call those. That's what we're kind of going with. And comparing with if you're unsure if one looks right or not, look at the opposite side. Let's say you happen to fall forward and break both wrists, and you don't have a lot to go off of. So we've kind of gone over this in the past, but we'll go over it again. First, primary survey. You're going to do your ABCs, AVPU, primary survey, and then identify life-threatening. Once we identify the appropriate interventions, if we have any, now these are kind of almost the same. Suspected extremity fractures or dislocations, cool, assess. We do the secure the backboards and transport. Splint if we need to, particularly with some injuries, because splinting can help a lot with pain many times, and sometimes it's just even used throwing a pillow or a towel, a folded towel or something underneath their arm, something like that. Or we can get into the old, there's a number of swing and sloth, a couple different ways that we can look at trying to transport these patients. Real BLS type procedures, and then look at pain meds too, guys. Pain meds for these in particular. Next, we will look at general principles of splinting. Goal is to basically immobilize the injured body part. Part of this is for protection and trying to reduce further injury. The other part that we'll really look at is to help ease patient pain. The goal with splinting is basically to, once again, immobilize the injured body part and decrease tissue to injury, bleeding, contamination of open wound, simplifies and facilitates transport. And sometimes it's particularly on longer rescue type ones, or where we have to get a patient for a while, but even right in the back of an ambulance, if their arm's moving around a bunch, if they broke their arm, for example, it can cause extreme discomfort to the patient as well as possibilities for other injuries. There's a wide number of splints out there, from really fancy commercial devices to I personally really like the SAM splint. Some of the agencies in the Valley have it. It's really useful. It's that flexible splint. We'll look over that in a minute. It just has a ton of use. Some of the other companies also will just use, and organizations will use cardboard splints. They work all right. Not always my favorite personally. And then there's any number of different ways you can do it. And if you're doing any type of outdoors, wildland type EMS, sometimes you have to make do with what you have, and that's where you start seeing things like sticks and otherwise being used. They're categorized into basically roughly three separate types. We have our rigid splints, or soft or formable splints, which are more like the SAM splints, and then traction splints, which are a very unique one and pretty important. You guys are all aware of our main traction splint we use in the hospital with orthopedic surgeons and some of the long-term injuries, either pre or post surgery. They have some pretty interesting traction splints. We can also just provide manual traction, which actually does quite a lot. So we'll start going over these individually. Our rigid splints, you can see here's a very commercial type device, cardboard box or cardboard one splints that we have on the AMR ambulances, and whoever else has those. Decently useful. They're not my favorite just because there's a little bit less lack of adjusting to different people's physiology or anatomy, and so they work decently. These look a little bit more not necessarily malleable, but customizable to each person. Formable splints, we look over here and we see this is the SAM splint. It's really easy just to kind of form. You can do any number of things to really make it more usable. It works pretty well, and it's just very flexible, both in terms of use and its actual moldability. Traction splints, once again, the one that we tend to see the most in EMS is going to be either the Sager or the Hare. We've had some practice using these in class during lab in the past, so I'm not going to spend an excess amount of time on the actual application or putting one on. That's more of a lab activity, but we'll tell why it's such an important reason to do that, and it's really used to stabilize and align the injuries, particularly with things like the femur. When you have very sharp, jagged edges across gigantic arteries really close, one, that it can cause further injury to those vessels if it hasn't already, and two, it's also very painful. If you've ever seen one of these, particularly that mid-shaft femur fracture that we're going to use a traction splint on, you see the muscles contort around there. One important thing is like some of our strongest muscles are going to be our upper legs, and how muscles work is they contract and relax based on two extra points. Those two extra points are on either side of that long bone, and so that kind of helps the leg muscle and move. As a contraction, it causes the different types of leg movements that we're working with. When you break that in half, now all of a sudden you have these very, very strong muscles pulling those jagged ends into the patient's flesh. That is typically what causes the vast majority of the pain. While there'll always still be pain there, that is a lot of it. And traction splints actually help relieve a ton of pain when we apply them correctly. So we really want to try and use those as much as we can for those mid-shaft femur fractures. And the discussion always comes up, I'm not sure if I hit it next, but it really, no, actually, so I'll talk about it right now. The importance of that is we apply some of it, when we do that, it are for open and closed fractures. Really, we can use them for either. It's good for either. Now, if you have the bone already coming out of the leg and exposed to the air, I'd be more cautious with using the traction splint. Not to say it's not applicable, but kind of see. And if I think more damage will be to pull it back in and pull it traction, then I might not do that. However, it is absolutely applicable for both open and closed. I was initially trained differently, and many of you guys probably have heard differently. That is from where I got the latest ones, and we will talk about it here. And if you guys need some where I can point that out, show you guys some areas in PHTLS as well. So we're going to start off with upper extremity injuries, classified as fractures, dislocations to the shoulder, humerus, elbow, radii, ulna, wrist, hand, and fingers, to include all the finger bones. It's very common in older adults due to their generally weaker bone structure in general. And then, as I've talked about in the past, we see it a little bit more in females because the loss after menopause or postmenopausal due to the loss of circulating sex hormones, which is a big part of bone growth and strength. Men tend not to go through there. They do have a drop in testosterone though, but not an almost complete loss of that circulating sex hormone. And so that plays a big role in osteoporosis, and we see a high propensity for older females postmenopausal to have bone injuries. Next, we'll talk about shoulder injuries. Shoulder injuries can happen in any number of ways. Many times it happens, particularly when they fall. You'll stretch your arm out, or say you're riding a motorcycle, you put your bike down and the handlebars get ripped out and jank your shoulder all around. We see it in football and other sports too, where they tend to fall or tackle hard. The shoulder is a very useful joint, but one thing as we talk about all these joints that's really going to kind of come to play is that the more useful and directions that you can move a joint around, the higher propensity it has to get injured very easily. So the shoulder, because it's basically at least triaxial, it can move in most directions and have pretty overall use. It loses a lot of stability because it's not able to really ball and socket quite as well. The hip, while it has quite a bit, it has more restrictions and it's a little bit harder to break once again. And the area that tends to break is the neck of the femur, right before the ball joint itself. But the femur itself, all around, is a pretty difficult joint to break. Joint, and by that I mean bone, but it works. And so we'll talk about some more of these. Where the shoulders, we can kind of see here that normally have this anatomy, we can see there is kind of the structure, but because it's held in place mainly by just tendons and it doesn't have as much bone support around that, we lose a little bit of that stability when injuries happen, and it can dislocate either front, lower, or anterior, posterior, so the front or the back, as well as can kind of move around some other areas. And because it is so tendon heavy, depending on what's kind of going on, how the injury happened, is it can injure some of those tendons or the ligaments, and then the tendons attaching to there as well. So there's a number of areas that the shoulder just becomes a bit easier to dislocate and injure. And the clavicle itself isn't the most solid of bones. Scapula is pretty solid, but. So here is a kind of what I was talking about with all the different number of tendons involved. Look about the bursa. The bursa is basically it's kind of sac of fluid around a joint. It really comes to play when we look at elbow injuries, because your elbow is a hinge joint, so it only basically moves and has one axis that kind of moves along. And it moves just in the two directions when you flex or you extend, but it all along that one axis. The joint doesn't really rotate itself. Your wrist does, your shoulder do, but your elbow's pretty there. And so when we look up here, we can see the clavicle, the AC joint, the different tendons that can get injured along with this, and then our ligaments as the bones kind of attach to one another. There's a number of areas in here that this tends to be a place where more injuries happen. We talked in chest trauma how the clavicle is one of the most fractured bones in there. So still a thing. And then when you break your clavicle, you lose even more, whatever stability, or an additional bit of stability with our shoulder. However, if we look on the backside and we talk about an injury to the scapula is a very big flat bone which has a decent amount of structure, and it takes a bit more energy to cause a fracture there. And that's where the actual joint itself with the synovial fluid and the bursa and all that is right in that area. Our acromion process right at the very top. The sternoclavicular strain or rotator cuff, which is what you hear a lot. That's where I injured my shoulder a little bit right in there. And depending on what ligament is injured, one, it's not anything we're going to diagnose in the field, but we can, PT's pretty good at it. As this x-ray, when they're x-ray will find fractures. And PT's really good, so physical therapy is good at identifying what ligament might be injured and really trying to hone in and work on fixing that area. So good ones. Humeral injuries. One of the harder long bones to kind of break. Big solid bone. However, just due to if you fall and you put your arm out and think that it can fracture easy, or decently easy, but many times you see either joint injuries and or ulna radius injuries as well. It's common in older adults and active young men. Radial nerve injury may be present and may cause axillary nerve damage that affects deltoid function. Anytime you got those sharp bones going anywhere, we can cause that. And temporal hemorrhaging, your brachial artery is a big artery. It can cause you to bleed out, particularly if it's an open fracture. So something to be aware of. Splinting and giving pain meds is the best way to work through this. Sam splint works relatively well, as well as a couple of other ones we'll look here in a bit when we talk about some of the splinting, some ways we can splint. So bursitis, remember that bursa joint, your elbow gets one decently in here and it gets this obtusely looking huge swellingness on the end of the elbow. So we can see the acromion bursa right here, and it will start swelling up. Most of the times that we see the elbow injuries in children and athletes, mechanism injury usually involves a fall on an outstretched hand or flexed elbow. May lead to some vascular disruption. As we can see here, because that narrowing of the area where all of our blood vessels and nerves have to go right through there, we have this with any type of injury to joints in general, but especially the elbow, we have a chance to pinch or cause circulation issues. We want to try and minimize any type of us reducing or causing further injury in there. We should not be attempting this in the field because we can really jack up those joint and nerves as well as circulation, particularly some of those nerves. If we mess those up, then they can lose use and function of different parts of their hand, which is a pretty big life-changing event. So something to be aware of. Try and make sure that we don't cause any of those. Can be a posterior motival splint, which we'll look at here in a minute, and if you need to, get a hold of medical direction to see how they want to, particularly if we have like a lack of any type of circulation or CSMs. So here's an example of immobilizing the elbow. We're not trying to do anything crazy, and one thing that this does pretty well is that it immobilizes below and above the joint, keeping the elbow at that area where we had good circulation and we're not going to cause any further damage. So remember, with the elbow, we're really looking at trying to limit further injury. Next, radial ulnar or wrist injury. Typically it happens when they fall out. There's the one that's kind of known as like the dinner fork. And one that I've seen this a lot on is snowboarders or even skateboarders, but working in a town with a ski resort, you see a lot of snowboarders fall forward and they'll put both arms out to brace themselves and fracture both wrists like this, which makes things really awkward for things, taking care of yourself in the bathroom, cleaning up, eating, almost anything, because they have a complete inability to do that. And they'll see it as they fall forward with both of those if they happen on both. So a Colles fracture is where it breaks outwards. They put their wrist kind of in the outward one and fall forward. Smith's fracture is where it goes in, and it can involve the radius, the ulna, the wrist bones, however many there are, I already forgot, somewhere in 12. I just had to memorize this, so apologize. There's any number of them. We're not going to make you guys memorize the individual wrist bones. Go take an A&P class if you would like to do that. There's a lot of them. and it's not necessarily applicable to what we're trying to do here as medics. So we're going to go on. Kind of managing the same way, this works particularly well with the SAM splint. You can roll up part of the end of the SAM splint, little ball, and then form it around the deformity, which is why I like the SAM splints a little bit more than I like the cardboard box ones, just because you can work around the injuries in people's normal anatomy as well as any patho injured anatomy that we now have to, that's not built like our bodies normally were. So hand or metacarpal injuries are next, often results from contact sports, violence, work-related crushing injuries. Talk about a boxer's fracture, and that typically happens on more the knuckle area, usually, and down into the carpals and metacarpals themselves, and more the metacarpals, and so metacarpals, carpals, and then your phalanges are the distal part. This is the middle of your hand, and with skin and bones, muscles, but has bones. Many times boxer's fracture come from hitting on the punching with your, when you punch, land the strike, and it hits your pinky and ring finger knuckles more because there's not as much bone support there. So most people, when they punch, they want to try and use your index and middle finger as your main striking area. However, in general, our fists, as much as it seems, and we see in movies of punching working really well, many times it's more important, or it's more effective to actually use a palm, like using a palm strike or some other way, elbows, which work great, just due to the weakness of our metacarpals and their lack of, there's a ton of tendons and ligaments all the way through here, but still there's smaller bones, and with the use enough force that breaks your hand easy. It's why boxers wrap, and MMA fighters and others wrap their hands and wrists, so they try and prevent that injury. And so it happens frequently, and your fist is not a fantastic weapon. So managing it is going to be applying a rigid deformable splint, sometimes using the blanket or pillow in a position of comfort or function, best for the patient, and it works pretty well. So here we're going to look at the actual boxer's fracture where someone, many times the reason it's called a box fracture because it's from a punch, and we can see exactly where that strike happened and where that fracture happened right there on that pinky knuckle, as I was kind of talking about previously. All right, we're going to look at our injuries to the phalanges. So we look up here. Here's where we have our 9 different carpal bones, the wrist bones itself. Then in our hand, we have our metacarpals, and then each of the phalanges has 3 separate parts besides the thumb, and the thumb has only the proximal and the distal phalanx, where the phalanxes of the rest of your fingers have 3, are proximal, middle, and distal. While these seem kind of minor, we can look at them and note that still can be a lot of pain. Pain meds are absolutely appropriate. If we can splint them in some way, it's something we can always look at. Sometimes that's not always the biggest priority in pre-hospital. That being said, still something to think about. All right, back now to our lower extremities in the pelvic fracture, pelvis, and then it can be a pelvic fracture. You don't dislocate your pelvis necessarily, but we'll have a fracture dislocation of the hip, femur, knee, patella, tibia and fibula, ankle, foot, and the phalanx. Much like the phalanx of the hand, our body has our hands and our feet both have similar nomenclatured appendages. So the phalanxes on both are there. You can further call them your first, second, third, fourth, or fifth phalange of left foot or right hand, whatever you want to call that. And then instead of carpals, we have tarsals, and instead of metacarpals, we have metatarsals in the foot. There's usually a greater associated force and more significant blood loss with leg and feet injuries. They're more difficult to manage and can have a high propensity for death and serious injury. Next, we're going to look at the pelvic fracture itself. So we already talked a bit about this in the GI section of our lecture, of our abdominal lecture, not necessarily the GI section, but as part of the abdominal cavity and what we need to do to try and stabilize this as best as possible. We'll talk about that. The pelvis. Here we're going to be talking more about the overall function of the or dysfunction due to a fracture of the pelvic girdle itself versus necessarily about the organs side, which is what we covered in abdominal trauma. And so it's a little bit of both. We'll do a little bit of review, and it's basically what we're going to try and wrap up on this. It's surrounded by a ton of heavy muscles as well as some soft tissues, very well protected as we talked about previously, but it does have that propensity to bleed heavily when injured, and particularly when the pelvic ring has been disrupted. So we'll look at some of this. So we'll talk about the pelvic stabilization device or pelvic binder in the next slide a little bit more and why we do that. But here's an example of some different types of fractures that we can see. So this is a pelvic ring intact. As each of these pictures is kind of talking about, talking about that posterior arch back here. And where these fractures can be without, so an intact, as far as the pelvic ring goes, we're talking about this entire ring right in here. The iliac wings and the crest up on top could be fractured. Lower area, also little protruded, can be fractured, as well as the coccyx and part of the sacrum. A little bit on this isn't actually part of the below that's shown on this picture. However, on here we see that in these areas, this is where an incomplete disruption of the posterior arch kind of happens. And remember, one of the unique functions of the pelvic, much kind of like the clavicles, is that, as well as just the shoulder joints in general, is that it's a little bit of a joining up of the axial and the appendicular skeleton structures. And that in the shoulder, it's not quite as much, even though there's more of the thorax there. But we do, down here in the pelvis, it's actually two separate parts of the skeleton that are basically fused together here in this joint. And so the sacrum is being part of the axial and from our spine, and then is connecting to the appendicular portions of the pelvic ring. And that's what we're kind of looking at right through there with our iliac wings. And then the complete disruption would be all the way through here, and this is where we get a ton of instability. We also get a lot of instability here, and when this is fractured, we start to look at open book fractures. So speaking of open books, we're going to look at here in this on our left here in a moment. The picture on the right we've seen in the past. This is just showing the very large amount of blood vessels within the human pelvis, and where any type of fracture within this bone can cause that chance of increased bleeding. And then when we do have bleeding in this area, where we need to try and make that area as small as possible, right? So if this person's pelvis would normally fit 4 liters of blood. If we put the pelvic binder on and compress that area, now would only be 3 liters of blood that could maybe fit in this area. And as the blood starts to fill that area, it starts to build up hydrostatic pressure, which then the aorta has to, or the aorta, but which could, or the iliac arteries or the femoral arteries have to try and overcome to continue to bleed in that area. And at a certain point, it'll start slowing that down, along with the constriction of vessels, particularly arteries, that happens when there's an active bleed. The arteries have a natural propensity to constrict, and that smaller area then has a better chance to clot. And then this poor fella over here, we'll look at the x-ray real quick. We can take a C. Looks to be dislocated right hip. You can see the head and the neck of the femur right here kind of pushed over in front of the pelvis. We see the disruption of these lower arches, and then the open book fracture right here in the middle, which is it's cartilage, as we see over there. And you can see the huge amount of blood that, if we look over this picture, right, where all those blood vessels are coming through, and why it's so important. If we think of trying to put any type of pressure on this, if they're complaining of this pain or we see all this, we need not to put pressure on this pelvis, because this unstable pelvis, if we put pressure on there, can cause any of these jagged ends of bone to lacerate any of these numbers. And we can kind of look where all these blood vessels are going through and how easy it would be. So this is why we bind the pelvis. Here's an example of a commercial device for pelvic stabilization, pelvic stabilization device. This is actually a very interesting one in the sense that this is also a junctional tourniquet for the hips, and it will put pressure in the inguinal area so if this is bleeding, what you do is either this has two, or even if it's one, you can move one to the other. It's just a little luer lock right there. You puff this up and it you squeeze this, and what it does is it pushes air in there as it continues to compress. So you first place this on like we would a normal pelvic binder right over the greater trochanters, and then we stabilize it and we start inflating these, and this just puts direct pressure right on the area that the bleeding will, or even if the bleeding is distal, but we put pressure on this area, it'll stop all blood flow down, which in the case of an inguinal bleed or any type of femoral or iliac bleeds in here, as well as aortic, it'll cause that bleeding. It would be up here, but further down. And so this is a notoriously hard place to stop bleeding, and has killed many people, but also particularly different types of service members where they get shot and or shrapnel in this area. And this is where this device really kind of shines. But this still can be used as a normal pelvic binder, and it works great. There's other ones that are similar, but without these, as well as what we've talked about in the past, which is a sheet. And as we can see there, it's right across those greater trochanter. You pull it close, you close that space up, and you stabilize the pelvis. Fantastic. Hip injuries. So many times people associate hip injuries with pelvic injuries, and while, as we saw in that one x-ray a couple ones back, that is a possibility many times, but when we talk about hip injuries, they're usually talking about somewhere in and around the hip joint, which tends to really what happens is most of the time it is the femur, particularly the femur neck and head in here. You can see the greater trochanter. What we do, and we see this once again in the older folks that tend to have not as strong bones, because as we remember for A and P, when bones strengthen or weaken most of the time due to increased muscle mass because the muscles attach via tendon to different parts of the bone. They use those bones as basically grips holding on, and then they compress off that, and that'll become more important in another part here in a moment as well. But as more pressure and bigger muscles as they put more pressure on here, what then happens is that pressure the body notes that, and because bones have the ability to grow and add on as needed, as well as self-repair, one of our few systems that actually completely remodels itself all the time, it starts to grow stronger bones as people become more sedentary, and as well as older with different things like osteoporosis and whatnot, they lose a lot of that stability and the muscle mass that comes with that. And when you lose the muscle mass, you also lose the bone mass. Those go together very similar. And so what happens with the elder folks, they have a little less coordination. They will fall, break their hip, and these are particularly devastating when we talk about how a very healthy for an elderly person can fall, break their hip, because they're very active. They had hardly any health issues. However, they break their hip, and all of a sudden it can be debilitating, and many times their life expectancy drops significantly. One of the studies I remember seeing was something around many times the hip injury, their life expectancy will shorten to almost 2 years. As in, after this injury, they won't live past 2 years, because it becomes they lose all their activity. When they lose that, they start having all these other issues as well as infection. They're now sedentary. They don't have everything that was keeping them going, and they don't live nearly as long. how we can really identify some of these. So when the hip is fractured at the femoral head and neck, the affected leg is usually shortened and externally rotated. So normally our feet are pointing pretty anterior like. When they break that hip, and they have that fraction, that neck and head area of the femur, that foot is now facing outwards laterally, and it is shortened as well. With a hip dislocation, the affected leg is usually shortened and internally rotated, so facing medially. And fracture close to the head of the femur may manifest similar to an anterior hip fraction, shortened and internally rotated. So these are not hard rules, but it does give you an idea on a possibility of a fracture versus a dislocation. Next, we're going to look at the femur bone itself and femoral injury. It usually results from major trauma. It is one of, if not the strongest bones in our body. Particularly, it is the strongest long bone. And then what happens is we can see on here in this x-ray, very interesting in that we see one, it looks like very sharp dagger-like bone shards going in either area. Remember, the femoral artery and vein run right along here, and these now have a chance to lacerate that. Also, as I was talking about in the previous slide, when we have the muscles that grab onto either sides of these bones, and they normally, as when you need to move a muscle, it contracts and pulls those together. But they're held apart by the ends of the bone. When you lose this, and the long bone is keeping them at that correct length, and when you have this fracture, all of a sudden you don't, and the muscles contract and pull these bone shards into the thigh. And we can even look at the swelling difference. Look how much swelling is on this particular guy right here on his right leg compared to his left leg. Pretty dramatically a lot of swelling, whether that is bleeding or just the muscles itself being compressed in a smaller area just due to it being dislocated or fractured. So this is a midshaft femur fracture. And here, usually the shortened leg is externally rotated, mid-thigh swelling from hemorrhage, and can be life-threatening. It's going to be immobilized in the field with a traction splint. So that traction splint is really going to be what's the biggest lifesaver here. So if we can pull these bone ends apart and line them up to roughly where they're natural, there's always a possibility of causing that a laceration of that artery, but most likely we're going to fix that. And if we did try to move a patient like this, we have a much higher chance of causing that, even just the movement of the body to try and stabilize them without doing that. As those muscles contract, there's nothing there to really keep those bones in place, and so they'll go and they have a high chance to lacerate that artery anyways. So that's why we use the traction splint to try and reduce that as well. And so contraindications when we're talking about those traction splints will be any type of fracture to the head, the femur head, femur neck area, lower fibula or tibula fracture, because then the traction splint will pull on those, and those are more easily pulled apart, or lower leg and lower leg muscles than the thigh and those bones. And so any type of fracture other than a isolated mid-femur fracture is contraindicated. Now the better question is, what about an open versus a closed? The closed we use them for either. If the bones on both of them are sticking out, I'm not as concerned necessarily if we have both ends coming out. If you just see the end of one, the other bone is still in there getting compressed. And in general, they absolutely throw traction splints on open fractures all the time. But once again, mid-shaft femur fractures, that's where we're using this. So our next slide is looking at the different after this is done. And so we can see here, this is before this patient had these fractures, the traction to heal these fractures. We can see the two bones getting pulled together. This is the same leg, and we can also see the swelling that's involved with that. And a lot of that is just the muscles getting pushed to either side. On the other hand, we see when they're pulled apart on how easily how the bones line up relatively well. While this isn't as crazy jagged and looks like a knife in the middle of his thigh, it's still pretty they're pretty sharp and can easily lacerate any of the vessels in this area. But blown it apart, all of a sudden you can see this relief, or you will see the relief when you do this on a patient, but you can see how much better it lines everything up and how it makes the anatomy that much better. You will watch these patients very easily as soon as this works better than pain meds. And even with pain meds, I add ketamine for this and that subdissociative dose. However, it still adds a little bit of them not carrying quite as much, as well as hitting those opioid receptors. It works quite well for injuries like this. And then I get the traction on as soon as possible. You will watch their pain go from a 10 out of 10 in excruciating pain, because remember, those muscles are pulling these sharp edges into each other and just causing an insane amount of pain. And when we fix that with this, you'll see the relief almost instantly on their face. It's magic. I love it. So that's pretty much it. We can see this looks to be this looks to be the Sager versus on the one side, and then we have the hair splint, which is a two-legged on the other. They both work pretty well. One thing I would also think about is if you're, say, way out away and you're calling in flight for someone, there's some helicopters that don't do nearly as well, particularly with the hair where it has both of those, because the end of that traction splint goes about 6 to 8, sometimes a foot longer at the end of that foot. So if the patient's tall and you're going to fly them out, think about maybe getting a hold of flight to see if they have a helicopter that can handle having a traction splint. Not a big issue, really, if you need to and the patient's in a ton of pain. Many times the flight crew can work around that, but it might be something to think about, particularly if they're close. And because the flight companies should have one that fits in their helicopter a little bit better. We had one, it was telescoping, it worked pretty well, and it didn't go so far distal to the end of their foot, and it worked really well. So just something to think about. It would not necessarily completely affect my care, but it might be a consideration to have if you can if it comes to mind and you have the time and the patient can tolerate it the short wait. Next, we're going to talk about knee and patellar injuries. Knee and patellar injuries, much like the elbow, there's a ton of blood vessels and nerves that go all the way through the joint. We have a lot of tendons and ligaments all the way through, particularly a ton of ligaments. And again, the issue with ligaments when we have an injury to that is, one, they heal very poorly. Reason for this being they have very little circulation going through there, have enough to kind of keep those going, but they don't need a ton of active circulation to keep those areas up. Being said, when an injury happens, they are very, 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 very slow to heal, and that's why some of these injuries can be so devastating to athletes that happen. We'll look at the knee here in a minute. We don't try to reduce these if we can in the field. Leave that to the experts and just try and support as need be. A patellar injury itself, there's not a ton of tendons all the way through there. They have a couple keeping it in ligaments, keep them kind of in place. There's a popliteal injury that's more towards the posterior of the knee a little bit, and it is a pretty big blood vessel, big old artery, and we need to be cautious of that and be aware. And it could be pinched off if due to a bad enough knee injury, and we can have a lack of circulation to the most of the foot after that. So something to think about. No traction splint on. Don't use it if they have any type of knee or patellar injury. The knee's too unstable at that point. So here's a look at some of those ligaments and where they are in relation to and where they connect to. The knee, while it's still a hinge joint and moves roughly in one kind of axis, it does have a little bit more mobility, and it has a lot more possibility of injury to it. So just because we have all of our weight moved on it, it's a bit more sturdier than our elbow in many ways because it's used to putting our weight on it. But particularly with certain injuries that can cause a shifting of the movement to some of those other axes, particularly like lateral movements and rotational movements, can really cause injuries. You hear particularly the ACL, the anterior cruciate ligament, one that you see a lot in football players. They'll from that kind of lateral motion moving. They'll plant their foot and it won't. The rest of their body will kind of shift over and it'll tear there. You have your LCL, PCL. There's a number of these that we have to be aware of, and it's not nearly as important for us in the sense of identifying what ligament is injured, but we can see how just knowing how many ligaments are holding this joint together is pretty telling. Something that we should be aware of. So lower extremity injuries, we have our tibial and fibular injuries, most frequently fractured long bone, and if associated with knee, popliteal vascular injury should be suspected with that lack of blood flow to the distal area as well as bleeding in there. And if it's an open fracture, be concerned for that. We also have, this is because it's so common, I broke mine while I was on deployment. No cool story behind there. Ask me about it, class, if you would like. Being said, still two bones. Most of the time, the fibular, if break tibial, many times the fibulars. Mine was right here, right above the tarsal and metatarsals tarsals, right about here, all the way across. Nothing crazy, and just splint it. Pain meds, typical. Nothing crazy, unless now we talk about open fractures in a moment. There's some extra concerns with that, but it's a lot smaller space for the blood to fill up in, but still be concerned about it. Foot and ankle injuries happens quite a lot. Crush injuries that fall from height, violent rotating twisting force. Patients usually complains at that point tenderness, hesitant to bear weight on it, and we can have any type of tendon or ligament injury in there. Very common. Many people roll their ankle. Wear good boots. It helps out a lot if you're out hiking, things like that. Ankle support's an important thing. All right, open fractures. Patients' open fractures require special care and evaluation. One, all of a sudden this limited space that some of this blood can only fill up so much. Still got to worry about compartment syndrome, all that, but it's really somewhat limited. When all of a sudden you open this to air, now they can bleed out all the blood, right? And something to be concerned about, the bones themselves can bleed themselves. Everything is considered an open fracture if there's a break in the skin anywhere where we suspect there to be a fracture at. So if there's some deformity, swelling, anything like that, and we have a chance and we see an opening, not necessarily saying the bone caused it. However, it's still an open fracture, just simply because now we're exposing that compartment to air, and that's something to think about. That now they can continue to bleed out of there. So they're going to be treated in hospital by debridement and fixing up of the bone and injury as well as everything else. So this automatically goes from, oh, this is a small injury to, this is a pretty big deal. Like it almost always requires surgery, and we should take them to a trauma center if we can. Even if it's isolated, it doesn't necessarily have to be a trauma activation, but we should look at taking them to a trauma center. If the bone ends or fragment is visible, covered with saline, moisture, gauze, and then splint that as best we can. All right, so in this area, there's different stages of bone healing. What first happens when there's a fracture in the bone? We have this, it's broken down into multiple different stages. The hematoma formation's the initial part that really happens. And so big old hematoma, blood flows in there, and then we start getting a fibrillar vascular tissue that kind of goes in there, and it really helps stabilize as much as possible, particularly all the small bone fragments, and causes them from causing increased damage to the microvasculature. Then the granulation tissue starts to form. Everything starts to harden up. All the osteoclasts start coming in, and we start to see, osteoblasts, not osteoclasts, blast build, clast destroy, blast come in. They start building all this extra tissue. The hematoma starts getting removed. We see down here it happens a little bit more. The osteoblast proliferation really starts building all this bone around here. We get to the bone remodeling, where then the osteoclasts that remove a bunch of the extra bone tissue end up removing all this extra the bone around there, and then it remodels itself back to roughly where it is. Many times where there's an injury, there will be extra bone tissue built that the osteoblasts go in there and build, and depending on how bad it can leave that. They can increase the size and the strength of that because the body noticed that there was a weakness there, so it tries to build up that to be stronger. But they still have a propensity for injury sometimes, particularly if it didn't heal well. And this is where, if it's not splinted correctly, the osteoblasts will go, or when it goes to rebuild, it'll now be rebuilt in a different way that's not what was initially intended by the body in our DNA. All right, straightening angular fractures and reducing dislocations. We typically don't reduce dislocations. That being said, if there's a lack of circulation or sensation or motor, we have one chance to go in, try and reposition it. That does not involve the elbow. Elbow we leave as is and get to where it needs to go. And we reposition. You go till you add resistance till the alignment's felt and splint without reposition. We don't do this very much except when we're looking at trying to get circulation going back. One time, doesn't work. We don't keep doing it. All right, guys, that's it. If you have any further questions, go ahead and write them down, ask me in class, or send me an email. I'll get back to you. Thanks, everyone. Hope you have a great night.